Hi, my name is Ben DeVos, Marketing Associate at Unbound Medicine. Welcome to today's webinar where Dr. Jordan Perlman will discuss the potential for over-the-counter continuous glucose monitors in mitigating diabetes risk. This webinar will explore the potential impact of this new technology for patients and equip you with the latest emerging data for more proactive and preventative care. Now, let me introduce our speaker. Dr. Perlman is an assistant professor of endocrinology at the Johns Hopkins University School of Medicine. Her clinical practice focuses on using diabetes technologies in geriatric and disabled populations. She's involved in clinical trials testing new algorithms for automated insulin delivery systems. She has been recognized for her work on continuous glucose monitoring metrics and the associated risk of diabetes microvascular complications. Dr. Perlman was named a top doctor in endocrinology by Baltimore Magazine in 2023 and 2024. Unbound Medicine is the publisher and distributor of the Johns Hopkins Pocket Guides, which includes the Johns Hopkins Diabetes Guide. If you'd like to try a 14-day free trial of the Johns Hopkins Pocket Guides, scan the QR code on your screen. Dr. Perlman will be answering questions live following the presentation. To ask a question, please type it into the chat or Q&A box at any time. Okay, I'll turn it over to you, Dr. Perlman.
Okay, so thanks, Ben, for the introduction. This is a presentation on over-the-counter continuous glucose monitoring, which I'm guessing that some of you in the audience have started to see in your practices. The reason that we wanted to talk about this topic is I think it's something that's going to be pretty pervasive here in primary care. And as I'm sure a lot of you know, 90% of adults with type 2 diabetes are managed with primary care. And there are far more visits for diabetes in primary care every year than there are in subspecialty care. And so this is something that I would imagine that primary care doctors are going to see much more often than we are ever going to see it in subspecialty care. But I do find it pretty interesting that it seems as though primary care has less familiarity, I would say, with CGM in general than subspecialty care, as less than 50% of PCPs report ever prescribing CGM. It makes sense that this would be more common that they would in a Medicare predominant practice, as it is covered by Medicare and doesn't have the same prior authorization criteria that a lot of private insurance companies do. But so what your patients are hearing out in the world about CGM and specifically over-the-counter CGM is they're being told that they can learn how certain foods impact blood glucose. That's true. They're also being told that they can use over-the-counter CGM to help prevent blood glucose spikes. That's probably also true. But then, you know, there are these other claims that we've pulled from healthcare ads and social media that say things like blood glucose spikes increase hunger. I don't know if that's true. Blood glucose spikes impair concentration. I don't know. Blood glucose spikes reduce physical performance. I mean, probably not, because they're temporary. Blood glucose spikes cause depression. I haven't seen any evidence for that, any RCTs that demonstrate that. And then blood glucose spikes interrupt sleep. That's also something that I've never seen in any kind of formal study or literature review. So there's a lot of information out there that your patients are seeing via social media, hearing from their friends, things like that, that are going to make them probably want to get over-the-counter CGM to spend the money. But you know, kind of knowing what people are hearing and being realistic about how this technology can help is very important. So these are the two devices that are available on the US market right now. You have the Stelo by Dexcom and you have the Lingo by Abbott. And as of January 1st of this year, Stelo had over 100,000 registered users in the US, which means that over 100,000 people purchase this device. Now, we don't know if these were individuals who had type 2 diabetes or individuals who were just, using it to as a kind of a tool to monitor blood glucose as part of a separate health journey. We don't know why, but that's only a few months after launch. So that's a pretty astronomically high number. Before we kind of get into what these devices do, just so you know how a device gets approved by the FDA to be over the counter, CGM, it can have no alarms or alerts. It cannot have a finger stick calibration requirement, and there can be no reliance on accuracy. So for those of you who are familiar with insulin pumps and pens, those devices have a reliance on accuracy. So that's another reason that there can be no integration with therapeutic devices. The CGM cannot make any recommendations in terms of how patients should adjust their medications, and they can't be imported into any electronic health record system. So some of you, I'm familiar with Epic, some of you have Epic, may actually be able to directly see Dexcom and Freestyle Libre, the prescription CGM data directly in your EHR without accessing an external site, and that is not the case for Dexcom Stelo for the over-the-counter CGM. So this is a very busy table, but I wanted you to have all of the information. This is something that I got from the different companies about their devices. So we have the most information about Stelo. So we know that it's about $89 for 2 sensors, and 2 sensors are supposed to last a month. Stelo is about the same size as G7 for those of you who are familiar with the Dexcom CGM line. It's about 24 millimeters in diameter and 4.6 millimeters in height. It will transmit to somebody's phone from about 20 feet, which is less than with the typical CGM. Lasts 15 and a half days, has a warm-up time of 30 minutes, which is pretty quick. Has a limited measurement range, so from 70 to 250. So unlike a typical, Dexcom G6 or prescription CGM, the sensor will read below range and above range when it's outside of these values, as opposed to giving the person an actual number. So if your blood sugar hits 251, it's going to read above range. The MARD, which is an assessment of accuracy, is 8.3%. It's no different realistically than the G7. You can share it with your doctor via Dexcom Clarity, which you may be familiar with if you're familiar with G7. The device integrates with Apple and Android phones, and when it was marketed for patients who had type 2 diabetes not on insulin, and those who or those who did not have diabetes or prediabetes. And then the other device that's on the US market, which is right next to it, is Abbott Lingo. You can see that it's similarly priced. It's a bit smaller, but it has the same range of communication between the sensor and the phone. Lasts about 14 days, so a little shorter than the Stelo. Has a slightly longer warm-up. And a slightly narrower measurement range. So again, below 55 and above 200, the sensor is going to read below and above range, as opposed to providing an actual value. And they don't publish their MARD, which is a bit concerning. And there's a personal application that comes with Lingo that I've played with a little bit and is very user friendly, but there's no way for the patient to really share their data with a doctor or another healthcare provider. At present, it's only integrating with Apple, and it's been marketed specifically for, quote, health and wellness. So, what you pick for somebody or what somebody picks for themselves, should not so much, I don't think in this case, be dependent on price, but really, what people are looking for. And, this is all data that's coming from the company, but if you, go out into the world and you read kind of what people are saying about these devices, it's looking like about 20% of sensors, at least from Dexcom, are not lasting the full 15 days, and about 15% of the Lingo sensors from Abbott are faulting early as well. So, you know, you have to take all of this, I think, somewhat with a grain of salt. But this is kind of all the basic information that you need. We don't know yet when Rio is going to be on the market, but we're anticipating addition of Rio as well. So as a 30s something endocrinologist, I went out into the world of diabetes influencers on TikTok and Instagram to try to see, what actual people are saying about these devices and what you sort of may hear. So I follow a lot of diabetes influencers. So I pulled the top 20 diabetes influencers and I looked at their social media to try to see what people are saying about these things. And for Stello, people like that the program prompts them to enter their specific behaviors so that they can look back and say, hey, this particular food caused a blood glucose spike, or hey, this drop was when I exercised. They do report problems with repeated signal loss. So that's when the sensor and the cell phone fail to communicate. So there's no number displayed. They also say that the failure rate is higher than reported by the manufacturer. A lot of them have complained that when they call Dexcom customer service, they leave the call very unsatisfied. And then, just some aesthetic stuff. The sensors come with a paper colored adhesive overpatch, which apparently gets really dirty by the end of 15 and a half days. For Lingo, apparently the people find that the personal application kind of makes following your blood sugar a game, so it helps drive behavioral change. There's a specific counting tool that helps you track your blood glucose spikes. Some people say that the application itself doesn't have great color contrast, so if you don't have good vision, it can be kind of hard for people to see what's going on with the device. And then there are more complaints than with the Libre about adhesive reactions to the Lingo. When I asked Abbott specifically, they said they were using the same adhesive as was being used on the prescription Libre devices. So I don't really know what that's about, but that is something that I encountered a lot when I was perusing social media. So just to quickly talk about, where these devices, are appropriately used, there is some evidence for CGM benefits in patients with type 2 diabetes and prediabetes who are not treated with insulin. And we know that wearing CGM is well accepted by most patients. They like it. And it doesn't, cause them any significant problems. We also have some data from a couple of different studies that both time and range, which you guys know is a metric that you can see on the AGP report from Dexcom and also from Libre. We know that time and range and hemoglobin A1C both improve with continuous glucose monitoring in type 2 diabetes patients not prescribed insulin. There has been a 90-day study in this population that showed that time and range improved by 27%, and CGM showed that it improved GMI, which they were using as a surrogate for HbA1c. So that improved by 1%. And in fact, even in as short as 10 days, they've seen time and range improve by close to 7%, and A1C improved by 0.7%. So the benefit in terms of blood glucose control is real. There's also some older data out there in the diabetes universe about post-meal blood sugar spikes being linked to the development of atherosclerosis and cardiovascular events in type 2 diabetes. There is evidence that when you do oral glucose tolerance tests in people with type 2 diabetes not on insulin, that higher 1 and 2 hour post-meal values are more strongly correlated with the thickness of the carotid intima media and cardiovascular mortality than fasting plasma glucose or A1C. So the measures that you're getting on your routine labs that are helping you, sort of screen people for diabetes, but also, monitor progression of the disease are not as good in terms of predicting development of cardiovascular disease. And also, we know from even older data from the DCCT that there is metabolic memory for postprandial hyperglycemia. So, in patients who were in the tighter control group in the DCCT, now, decades later, they have less cardiovascular disease than those who were in the less stringent control group, suggesting that, there's something more than A1C that is influencing cardiovascular risk in type 2 diabetes patients. So there is not a lot of data on whether postprandial hyperglycemia causes the same effect on the vessels in non-diabetic individuals. Because the question that we really want to ask ourselves in the world of over-the-counter CGM is should normal individuals wear CGM to help reduce postprandial hyperglycemia? And to date, as I mentioned, most of the research has been in the context of diabetes, and so further studies in the setting of metabolic health and in the absence of overt disease is going to be needed to understand the impact of postprandial hyperglycemia on health and well-being. But there are a few studies out there that, for example, one showed higher peak, again, oral glucose tolerance test values in elderly patients was associated with an increased risk of developing atrial fibrillation. The association was thought to be specific to women. And so these were individuals who were an average of 77 years when they enrolled, and they were followed for 11.5 years. But these findings do suggest that interventions to address postprandial dysglycemia in this population could reduce atrial fibrillation. There's also a study of, there's also been studies that have shown that there's a linear relationship between your plasma glucose after you eat in patients who have a normal oral glucose tolerance test and the number of stenosed coronary arteries at angiography, meaning the higher that you go, even within the normal range on an oral glucose tolerance test, the higher likelihood that you're going to have more stenosed coronary arteries. And obviously this study, had to account for things like hyperlipidemia, family history, other risk factors, but this is what they found. So another question that is really difficult to answer is what is actually normal on CGM? And actually, this is such a hot topic that there was a commentary on this published in The Lancet just a few days ago on February 6th. The reality is we don't really know. There's been about I would say 1.5 studies on CGM in non-diabetic, non-pre-diabetic individuals. And what they showed was that, the time in tight target range, so the time between 70 and 140, people spend about 96% of their time there. And when they were looking at what they define as a diabetic range excursion, what they were calling a single blood sugar greater than 200, 50% of healthy people had these diabetic range excursions. So, you can get CGM data from a patient who doesn't have diabetes, but not really have a good sense of what things are supposed to look like. And it's important to emphasize that per the 2025 ADA guidelines, there's really not sufficient evidence to support the use of CGM for screening or diagnosis of prediabetes or diabetes. And there are no specific CGM metrics that are published diagnostic criteria when you look at the ADA website. So just something to keep in mind. So if you're asking, well, who, is going to benefit from over-the-counter CGM, we've said people with type 2 diabetes who are not on insulin because of the ability to maybe reduce postprandial hyperglycemia and, that the effect on cardiovascular disease. But if you're talking about healthy patients, and you're wanting to know if, you can actually use CGM to detect prediabetes or to see if somebody is at higher risk for diabetes, you need to ask that question. And CGM does show good correlation with peak post-meal blood sugars in patients who have abnormal fasting blood glucose. So, we know that if somebody already has dysglycemia, we can reasonably depend on CGM to identify that. We also know that CGM has detected abnormal blood glucose excursions that were missed by oral glucose tolerance tests in obese relatives of type 2 diabetes patients. So, maybe CGM is picking up high blood sugars that our usual diagnostic tests are missing. We also know that there are several AI algorithms that are in development that claim to be able to detect dysglycemia from less than 12 hours of CGM data. In fact, there at the 2022 Neuro IPS conference, Click Applied Biosciences showed some of their data on this, and it's pretty impressive. But it's important to understand that, even if you put a CGM on a healthy person, there is significant hemoglobin A1C, average glucose discordance between, your blood tests and your CGM in certain populations. I mean, particularly those who have anemia, who have chronic kidney disease. But, in some individuals, we never understand why, but the CGM estimate of A1C and the A1C really never line up. So you are taking the risk that you put someone on CGM and it comes back with an A1C or an estimate or a GMI that is completely different than what is actually measured by the lab data. So, if we do start using CGM to try to screen for prediabetes, we need specific criteria to determine who might be appropriate for this type of screening. So another reason you might want to use CGM is to encourage behavioral modification in patients that you think are at risk for diabetes and prediabetes. And, there was a Harris poll that was conducted on behalf of Abbott that showed that a lot of people said they would change their habits if they were wearing something that gave them personalized coaching that told them that they should change. So there have been several studies of this. One involved obese non-diabetic patients who wore CGM and got regular health counseling and reported that they were much more motivated to exercise. There have also been studies used to assess adherence to dietary modifications in obese patients who were not diabetic. So, if you're telling somebody, hey, we want you to limit your carb intake, and you see a whole bunch of post-meal spikes on CGM, you may question whether the patient is adhering to that dietary advice. And it's also been shown that regardless of a patient's past medical history, whether they have diabetes or they don't, the feedback that they get from wearing CGM makes them choose healthier, make healthier food choices, particularly foods that are lower glycemic and tend to spike the blood sugar less. So I think the final question here that we really need to ask before we start using over-the-counter CGM is, so we can look at this, but should we? And the first thing I want to point out is that for the average person, $100 a month is still extremely expensive. And I would question whether this is how we really want patients to be using their limited financial resources. The other piece of this is that, there is a lot of physiologic blood glucose variation, and you're going to get a lot of people who are going to be extremely scared by what they're seeing on their device, and, asking you for counsel. And we really don't have any guidance on how we should be counseling these people. There are also these biologically insignificant drops in blood glucose that can occur when you're wearing CGM that are either inaccurate or just not important. And people may react to these by, snacking and therefore causing weight gain. So there's a lot of potential for consequences there. We also know that CGM can sometimes read falsely low during the first 24 hours of wear. And there is a compression artifact. So if people sleep on their sides and they're sleeping on top of their CGM, they can get false hypoglycemia. And I think the other question here too is, who is going to pay for the time that it takes you to interpret over-the-counter CGM? And who's going to give you guidance on how to do that? Because that doesn't exist now. And then finally, this is a question that is, I think, probably less important to a lot of people, but overall, this is going to have a huge environmental impact if people start wearing these disposable sensors who don't need them. It's going to create a lot of waste, a lot of plastic waste that we don't need. So I do think that, CGM, over-the-counter CGM could be helpful for patients who are at higher risk for diabetes. They have a family history. They have specific issues in their past medical history that could make them higher risk for diabetes. Maybe they're prescribed steroids. But we really need to have a better assessment of who this will actually benefit before we start recommending that patients use over-the-counter CGM. And these are all the works cited in this presentation. I think there are 2 pages of this, but if you have questions about specific studies, you can definitely reach out to me and I'll be happy to provide those.
Hi, Dr. Perlman. Well, I want to thank you so much for that wonderful presentation. That was very informative, and I'm sure a lot of people got a lot out of it. And thank you to everyone for tuning in today. We do have time for a few questions, so please put those in either the Q&A box or in the chat, and we'll be sure to get to them. I do see that we have a few questions already. So, Dr. Perlman, given the FDA requirements, what is the most effective way that patients can use these devices without the features found in prescriptive glucose monitors?
I think, the most important point here is that they can't use them for alarms, right? So if you've given somebody medications that have a significant side effect of hypoglycemia and you want patients to use these devices to avoid hypoglycemia, over the counter is not going to be sufficient. Luckily, the majority of the medications that we prescribe that are non-insulin medications for type 2 diabetes should not cause significant hypoglycemia. And most insurance companies, if your patient is on insulin, will in fact pay for prescription CGM.
Thank you so much. Another question that someone had was, how should patients evaluate online reviews and information about these devices? And how would you recommend that clinicians guide patients through this information?
That's a very, very good question that I don't have a great answer to. I mean, we all have people who come into our offices just saying, hey, I read, XYZ, on the internet, and is it true? I think, I think that reviews of the device's functionality all need to be taken with a grain of salt in that, you don't see a lot of people on a lot of these online review sites that have had a good experience. Most of these people are people who've had a bad experience. And so, I think that, if the question is, well, I want to do it, but I'm afraid other people don't like it. I think in that regard, we definitely should encourage people to give it a shot themselves. I mean, this is just a much broader issue, which is that, medicine is being practiced in chat rooms. It's really hard to try to correct a lot of the misinformation that people are finding on social media.
Absolutely. I think we have time for one more question. So you said that less than 50% of PCPs report ever prescribing CGM. What are the biggest barriers to CGM prescription in primary care?
That's a good question. I'm not a primary care doctor. I'm an endocrinologist. So I think one of the things is probably support, particularly if these prescriptions require prior authorization. I think that a lot of offices do not have adequate support to get prior authorization for these devices. I think the other thing too is that, I think it depends on when and where you were trained. I mean, a lot of primary care doctors who are a little bit older really don't have the same confidence in CGM as a tool for managing diabetes that I think some of the younger physicians do because we quote grew up with CGM. But I would definitely say I think it's office support is the number one barrier.
Awesome. Well, once again, Dr. Perlman, I want to thank you for your fantastic presentation. I hope everyone found this information valuable for the future. A video of the presentation will be provided to all attendees and those who signed up for the webinar, so please be on the lookout for that in the next week. At the end of the session, we'll be distributing a survey, and your feedback is very important to us, so we would greatly appreciate if you could take the time to fill that out. It'll help provide more webinars from Unbound Medicine and Johns Hopkins Medicine. In addition to Dr. Perlman, I want to thank everyone for attending today. If there are any questions about this webinar or future webinars from Unbound, please contact us at webinars@unboundmedicine.com. Once again, thank you so much, Dr. Perlman, and I hope everyone has a great day.